Well, we've been sent another case for evaluation, and the notes on the case is thanks, Jerome, for reviewing this plan. It's my pleasure. I'm sure I will have to alter the adjacent teeth to allow the guide sleeve to seat, and I see that the palatal side of the implant may need some grafting. So we'd like to take a look at this. A couple of things in this particular case that pop up into mind here. So first I'm going to go ahead and duplicate this so we can work off of my plan. Let's talk about the first thing is we can see here that we have these radiographic markers right here, and here. So that means this case was set up as a potential CCAT Classic guide, but we can also see that we have our CEREC data in here as well. So that means that even though we may have thought this could be a classic guide, we have enough data and the integration is there to be able to do this as a digital surgical guide, being OptiGuide, DigiGuide, or a CEREC Guide 2. So all those options do exist for us in this particular case. So one of the nice things about setting up as a classic guide is that if that needed to be the case, you didn't have to bring the patient back, and you could just take this bite plate, rip out the bite registration material there, cold sterilize it, and certainly use it again. So good thinking there. Next, we'll go ahead and take a look at a CEREC design, and in looking at this, it looks extremely good actually. So right here we can see our gingival margins, just like so, just like so, just like so, just like so. So that gingival margin flows very well, so our margin was drawn correctly here. And then as we look at it from the occlusal, we can see that our buccal and lingual contours, are pretty good here. Just like so. Just like so, so everything looks very good there. Now, you did make a comment regarding having to adjust for the sleeve, and that is a potential here. We'll have to take a closer look at implant sizing, different things like that. But one of the things I wanted to point out here is if we are planning on doing that, or if we have a good guide, good plan that's what we're going to do, let's take a look at where does it need to be. Does it need to be equally here, or one just here, or just here? And one of the things I want to do here is I want to point out that the way I would probably look at doing this particular one is knowing in advance is I would pause probably in this particular case. I don't necessarily love the contour of this tooth right here. I might actually cheat and take it all from tooth number 12. And then what I would do is I would mentally adjust my implant positioning, so then I would mentally maybe have my implant crown going to here, my virtual wax up, and then instead of the center of the tooth being right here, the center would actually be somewhere right in this ballpark, just a hair over. And then I would make note that I intend to adjust just the distal of tooth number 12 there. So hopefully following along with that, and that makes sense. So we'll go from there. And again, the reason I'm doing that here is this tooth looks like A, it has a restoration, and B, it looks like it's maybe a hair bulky on the distal side of that. Just from right here, I can get that feeling. So I would probably cheat a little bit more off the distal of 12. So let's go ahead and take a look at our plan here, and we'll go through our checklist, buccal lingually, where technically we're not well centered to the ridge, but what we do know is that this is where we want it to be. So here's our ridge. Just like so. And then if we were to be well centered, so here we go, and so we can see here that's our ridge. So technically our let me redraw that, sorry I lost it. So there's our ridge. So being centered in this particular case would be probably like so. But we know that by having this tooth right here, we know that that's not going to be correct. And this is a great example of how many sometimes surgically driven implant placements are going to be incorrect, whereas prosthetically driven implant placements, this will be quite nicely done there. In buccal lingual, in this particular case, I'm going to look that I have enough bone all the way around. I'm a little tight here potentially, so maybe, just maybe, I'll drop it like so, but then I'm off center here, so we'll leave it like this. I'm very comfortable with that bit of gap with the accuracy of a surgical guide there. Next, we'll look at mesiodistally. Mesiodistally, we look pretty good here. We're plenty between the roots. We got plenty of space there. No problems there. Also take a look and note for those watching that we use the findings tool right here to go ahead and mark that there's a radiolucent aspect right here for the patient to look at. So I love seeing that in using the software. Next is bone level. Our bone level looks pretty good. The only thing I would possibly mark here is that since this is our margin right here, we don't have a lot of room to develop our emergence profile right here. So I might consider dropping this implant just a hair to allow for that, maybe somewhere along the lines of something like that. And now we have a little bit more room to design our emergence profile. This bone right here will go away just from the osteotomy itself. So I would do something along that line pretty comfortably there. And here we can see that we're still not quite into the sinus with that. Okay, so bone level, I would make those minor changes. And then vital structures, roots are no problem, sinus is no problem here. The buccal plate is a hair thin, but again, I think we're going to be okay. Worst case scenario, if let's say if we weren't comfortable with that, we could just cheat a hair, and we're still going to have screw retained access here. Just be a little bit to the buccal, the hole, versus being to the lingual, but still more than adequate there. Next, we'll look at our occlusal table. Our occlusal table looks very nice. Everything's pretty well centered. We can see our sleeve is already in there, so we can see that we're there. Our occlusal plane is just a hair off here. Okay, so when I look at our occlusal plane, what I'm seeing is like so, and what I would like to see is probably like so. So I know why this is that way a little bit. One is we're trying to avoid that sinus, and two, we're trying to fit everything within that sleeve. Now let's go back to worried about that mesial of the distal of number 12. So when I tilt this implant over, I'm going to run into the mesial of number 12. Okay. But now my occlusal plane is going to be a little bit better, and I'm not overly worried about the mesial of number 12 here, because I know that I'm going to be taking away more of the distal of 12. I'm not overly worried about that because I'm going to be taking away more of the distal of 12 and leaving number 14 alone, so that way I can get a more ideal size restoration or tooth form there. So that being said, I think we can probably just cheat. There we go. And now I think we have a very good plan. We'll go through our 360. You can see that we're butting right up against the sinus but not going into it. I think that is more than adequate in this particular case. I would not be overly worried about that. My only area of concern, as you can see right here, is we are pretty tight on that buccal plate. So maybe in this particular case I would just choose to go ahead and tilt a little bit that way, just to avoid potentially perfing out of that area there. And then in terms of that lingual bone, again, I'm not overly worried about that. I don't think that's going to present too much of an issue for us. So very well done plan and a great educational piece there. So thank you very much for submitting a case.